welcome back. We have the last keynote speech for the Congress, and it's going to be not in the mood about hormones and sexuality. And Professor Dr. Schultz is going to give a keynote speech. And let me introduce you, Dr. Schultz. Professor Dr. Schultz is from the Netherlands. He was in Nigeria as a tropical doctor from 1976 till 1978. He is general gynecologist for the last 34 years in Groningen. He is the head of the Groningen gender team and head of the Sexological clinic of the Groningen University Medical Center for the last 24 years. He is the chair of education committee of the Department of Obstetrics and Gynecology, UMCG, for the last 23 years. He has experience as a sexologist and VVS 18 years, and for the last 13 years he is core curriculum teacher and course coordinator and editor-in-chief of the Journal of Psychosomatic, Obstetrics and Gynecology. For 10 years, Dr. Schultz is the member of the board of STEMEZO and the Center for Sexual Health in North Netherlands. And over the years, he had various positions in the working group Psychosomatic and Gynecology, the Dutch Association for Sexology, and the Scientific Association for Sexual Dysfunction. He has more than 177 international and 250 national publications. Since 2005, he is the professor of psychosomatic obstetrics and gynecology. He has played an important role in the development of psychosomatic and gynecology and sexology in the Netherlands, but also on abroad. In the course of his career, he received several awards, including the Professor Brummel Prize in 1991, the Betty Boss Olive Prize in 1992, the Hector True Foundation Fund Prize in 1997, the IG Nobel Prize in 2000, magnetic resonance imaging of male and female genitals during the coitus and female sexual arousal, and he was elected Clinical Professor of the Year in 2000. So it's my honor to invite Dr. Schultz.
Thank you very much. I realize that there are people for which English is not their native language. That's also not for me, so I will talk slowly, don't worry. But if I go too fast, just mention it and we will go more slowly again. So I'm going to talk not in the mood about hormones and sexuality, and it's a problem that existed for many ages. This is a painting from the 16th century from Rembrandt, one of his most famous pictures, with his wife Saskia. He married and she died soon after they get their first child. Now I want to introduce you Claire. She's from this century. She's 20 years old, she's a student and she is single. And she was referred to our OPD by the endocrinologist because Claire is so different. And especially her mother was concerned because Claire's 18-year-old sister had many different experiences with sexual relationships, and Claire none. It was like stagnant water. Claire had a medical history of a tumor in the pituitary gland. It's a gland on the underside of the brains. And she had to be operated and lost a large part of the pituitary gland. And after that she got substitution as usual, which means combined oral contraceptives from puberty. She got T-Rox, she got cortisol, and she got growth hormone. Here you see the pituitary gland, and this is producing ACTH, FGLH. These hormones control the adrenal glands in the ovaries, and they produce cortisol, androgens, testosterone, progesterone, and estrogen. So she got substitution. This when loss of pituitary, the whole control was lost, so she needed substitution. She got cortisol, she got progesterone, estrogen, but no androgens and no testosterone. So that was could be the explanation for her history, which was completely blank. No interest in sex whatsoever, no sexual fantasies, never been in love, never been sexually aroused. She never had an orgasm and never had masturbated. So the presumed diagnosis was possible testosterone deficiency, and the testosterone was measured and was outside the range of precise measurements. She got testosterone substitution, and after 6 weeks on checkup appointment, she reports the initial effect. What do you think it is? Oh. Any?
Dreams.
Doctor, there's this guy who lives near us. And after 12 weeks, Claire had her first orgasm. And on concluding the treatment, she told us, there's something else I wanted to tell you. These days, I understand most of the jokes they tell around the table. So far, Claire. In this presentation, first I will talk to you about why is sexuality important. Then about some basic things about the sexual response. Then where does sexual desire come from? Then we'll go to the hormones, estrogens and androgens, and then I will give you a summary. So the first question is, why is sexuality important? And that's a question you can divide in two. Why is sexuality important for all of us as we sit here? And why is sexuality important in times of physical suffering? I think sexuality is important because sexuality is an essential part of your sexual life, of your quality of life. In every culture, at every age, sexuality is part of your quality of life because sexual contact means social contact. And even if you want to avoid sexuality, you won't succeed because our society gives, from the moment you get out of your bed till you go there, continuously stimuli which have an erotic meaning, so you cannot avoid it. And why is it important in current times of disease or physical handicap? If you have a physical handicap or disease that gives sexual problems and you manage to cope with them, then this has a boost for your recovery process. But the other way around, if you do not succeed to overcome these problems, you get another problem, an unsatisfied partner who is not satisfied with your sexual life. So I think sex is important not only for healthy people, but also for people with an illness and handicap. And I think we should say especially for people with an illness or handicap. The next question is, why do people have sex anyway? So there are many arguments you can find, but there are within most cultures, 2 arguments within a relationship why people have sex. The first is the need for intimacy. What do I mean by that? Intimacy means involvement. You start a relationship with someone because you think he or she is worth to start this relationship. You can communicate very well, solve problems together, share emotions together. That must be mutual. And when this works, then the top of this pyramid is then the intimacy. You can do it like a pyramid here, but you can also make a circle of it. Another very important argument is the need for arousal, the need for sexual arousal. And this shows that sex is preeminently a psychosomatic event. The body meets, the mind meets the body. And that is wonderful envisaged by this psychosomatic circle of sex according to Willebrord. If you follow me, you can get aroused by external stimuli, what your senses perceive, what you see, what you hear, what you smell. You can get aroused by your internal stimuli, which are erotic thoughts and fantasies. That's the brain part of the story, the mind part. But you can also get aroused by being touched, and more intensively by being touched at your genitals, or by intercourse, which is nothing else than you touch with your genitals, the genitals of another one. It's also kind of touching. So this gives physical reactions, this gives genital reactions, you are aware of these reactions, and then the circle goes around until this ends into possibly a satisfying sexual experience. And on the background there are the standards, the values and the experience. We all have a backpack with our experience in this matter, which we carry during our whole life with us. What you will notice here is this dotted line, and with this dotted line I want to tell you that this mind circle can function completely independent from the physical circle, because you can purely by physical stimulation also induce a complete sexual response, including an orgasm. And the other way around, from psychological stimulation, the same can do. That is especially important to realize in case of disease or handicap. Here you see the 4-stage model of the sexual response by Masters and Johnson. The sexual response are all physical manifestations during sexual arousal. And in the period of Masters and Johnson, they had separate curves for men and women. And in 1980, Verveen and the researcher demonstrated that it is impossible by specialists to separate the curves of women from the curves of men. So since that period, we have one curve, and we have an extra phase in it, the phase of desire. We have arousal, plateau, orgasm, and recovery. The dotted area, that's the area where you are very much involved physically and mentally with your partner. That's also afterwards, but during orgasm and in the first phase, you are much more busy with yourself. And that's why it's called the solo phase. So it's very interesting that in sexuality, you give yourself, you make yourself very vulnerable to someone else, but so you are very close together, but at the essential, at the highest point, you are very solistic busy. So it's a potential between together and alone. But if you go back to the circle of intimacy, you can have a wonderful relationship, but sometimes you also think, I don't want to have to see you for a couple of hours. So that's the same kind of tension, alone and together. What is very striking in this model is that desire comes first and then the rest. So this is a linear model, and it is very orgasm focused. And this is a model which we still use in our patient care because it's very easy model to get a picture of the sexual response of men and women, but our thinking about how this goes is completely different, and I will tell you. First, the question, where does sexual desire come from? Anyone who has any suggestion, where does sexual desire come from? Mark.
Am I too old?
Where does sexual desire come from?
Instinct.
Instinct. That's interesting. That's interesting. You're not the only one who thought that.
Okay.
Right.
Partly biological, but then also partly environmental and social cues telling us what we should find. Sorry.
I will tell you. Where does sexual desire? One thing is for sure, and you must always remember, that's this. Remember that. So what is wrong? And now that's what you said. We had Freud. He was in the last century. Here you see his standard edition, 1953. So you are a little behind. But Freud thought that libido is fed by the sexual instinct, and this instinct emerges from a source within the body. He called it Trieb, the German Trieb, which is the same as drive. So he was saying it comes from inside. You cannot avoid it. So you cannot influence it as well. It's something which comes up. So nowadays we discovered, but it's not that wrong, because we only recently discovered that it is different. And that's because of this apparatus. In the last century, a lot of sexological investigation was done in men. And if you look what is possible for men to get their erectile dysfunction repaired, everything is possible. You have so many methods. But in women, research was concentrating on contraceptives. So we have a lot of contraceptives of women, but no sexual results. That has changed in the last part of the last century, in the 90s, with this instrument. This is a kind of artificial tampon, we call it a platysmograph. Light comes here, it is reflected by the vaginal wall, And in this way, we can measure changes in vascularization of the vagina wall. I will show you. If they look to a film, you see first this, and then an erotic movie starts, and then you see a much higher amplitude. So that means that we can measure sexual arousal in women. And it was a starting point for a discovery tour about sexual functioning of especially women, but I think this also has repercussions for our knowledge in sexual function in men. Because this response, when you show the erotic film, this response starts at the moment when you put a woman for an erotic video. Then you see this response in every healthy woman, young, old, pre or post-menopausal, regardless of sexual experience, regardless of the feeling that you think this is a very nasty film, it still occurs, regardless of arousal of desire, regardless of the dysfunction. Because it is an entirely subconscious phenomenon. It happens. You can compare it with the fear system. When you see a snake, your body responds like in stress, it's in full action because there's something very dangerous going on, and then you start thinking, and then you see it's just a tangle of rope. So, and that's the way how it works. And I think this is also in men. If you see this man on a row, this cannot be a cognitive response. For men on a row do not think the same. It's also an autonomic response. Only I do not know what the stimulus is, because this head cannot be a stimulus for this. So now I show you a model where you see that this automatic response is incorporated in the so-called information processing model of the sexual response. Here you see a stimulus gives a sexual meaning, you get the automatic subconscious response, but on the other side you start thinking and you evaluate what is happening. And that means that this erotic stimulus also obtains a non-sexual meaning. And we call this the attention process, and the attention process is conscious and slow. And that gives a subjective perception and then a circle effect. And this is the area where testosterone is involved. Remember that. And that's sort of the conscious and slow, the cerebral and mind part of the whole story. So what did we learn of this technique? That for women, the context of the stimulus is very important. That answers your question, Bill. Feeling like sex is no longer the starting point for sexual activity. Feeling like sex usually arises only after the woman has been in contact with sexual arousing stimuli. In women, there is a weak link between genital and subjective arousal. Limited subjective arousal can be accompanied by a normal sexual response, and conversely, a limited sexual response can be accompanied by a subjective arousal perceived as normal. So how does it work? Somehow you have this automatic response, and for the processing of this response, you have, on a cognitive level, to turn the knob. And when do you turn the knob? When you are motivated. So you must be motivated. And what are these motivations? In American literature they call it incentives. What are these stimuli, motor incentives? For example, to express feelings of intimacy, to experience feelings of passion, to feel masculine, to feel feminine, to feel normal, the feeling of sharing something very valuable, to experience the partner as sexually attractive. These are very noble motives, but there are also honorable motives, like to please the partner, or to make up after an argument, or to fulfill the duty, out of sympathy, out of loneliness, power, to avoid a conflict, for your career, and for money. And then, in cases of diseases of handicaps, motivation can be for relaxation, to reduce stress, to relieve pain. We know from the rheumatics, for self-affirmation, and to deal with emotions. So the word libido, which has been used up until recently, we do not use the word libido anymore. We use the word what is sexual desire. What is sexual desire? That's the sexual arousability plus the sexual motivation. The automatic reaction And what are you doing with the reaction? Desire is the decision to do something with beginning sexual arousal. That's the solistic point from Manson and Johnson. You choose yourself whether you are going into this sexual situation or not. It's your own choice. Thus desire is the decision to do something with beginning sexual arousal. Loss of libido, we don't use anymore, we call it hyperactive sexual desire disorder. And in the DSM-5 it's already mentioned different, so quick are these developments. We call it sexual interest arousal disorder. And the DSM-5 proposes 3 main criteria. And the first criteria is a tremendous amount of words, but I think I have to read it. Absolute reduced frequency of interest in sexual activity, absolute reduced frequency of or intensity of sexual thoughts or fantasies, absence of reduced frequency of initiating of sexual activity and being typically unreceptive to partners who tend to initiate it, absence reduced frequency or intensity of sexual cycle during sexual activity on most sexual encounters. In short, it's stagnant water. Nothing happens. Another criterion is the presence of distress or impairment. You must suffer from it. So if you are on an island and you have no sexual desire and nobody else on the island, you do not have a problem. So you really must suffer from it. And criteria C, the dysfunction should not be better accounted for by another disorder. So you can be in a situation, for example, relational problems, that having no desire is a normal reaction on an abnormal situation. So why do we need it? You have to change your relationship. As a sexologist, you will not tell a patient to change the relationship, he has to discover it herself or himself. So, and then it can be lifelong versus acquired, it can be generalized or situational, and there are specifiers like partner factors or relationship factors. So how does it work? Now the whole story comes. Instead of the linear sexual response of Manson and Johnson, we start here. Primary, there must be willingness to be responsive to sexual stimuli. These stimuli must be in an appropriate context, the environment, the neighbors that can listen while you are making love. Someone, for the one, it can be very exciting, and another one says, it stops. So the context, biologically and psychological, it should be okay. No disease or whatever factor or depression or whatever. Then you start processing sexual stimuli, which gives sexual arousal and sexual desire. So arousal and desire go together. No linear model anymore. This can result in sexual satisfaction, but also in non-sexual rewards, emotional intimacy. And that awareness of this positive rewarding sexual experience is the basis for the next time you are going to involve in a sexual situation. So it is a circle now, and it is around the difference is circle now. When the one who's taking the initiative, we mentioned sexual desire. When you in secondary instances become involved, we call that responsive desire. And what is very important, it's not only orgasm-centered, but it has also an emotional meaning. Is that so far clear? But there is another thing for the processing of stimulus. You must be motivated, but another thing is, it is important that certain conditions are met. And what do I mean with certain conditions? The system enabling sexual responses must be intact, and that are the transmitters and the hormones we're going to talk about later. Also, to activate the sexual system, there must be stimuli with a sexual significance. So the stimuli must be adequate, otherwise it does not work. And for sexual activity to occur, the circumstances should be adequate, and that's the characteristics of the situation. The capability of sexual cues to evoke an increase or decrease of the sexual motivational brain activity, we are talking about you must be motivated, depends on the biological characteristics of the individual, the psychological characteristics, and the social circumstances. At a cerebral level, we then think of prenatal testosterone influencing organizing of the brain exposure, which hormones are you working before you are born and who create your cerebral functioning. The sensitivity of the steroid receptor in the brain, and that's the world of the testosterone. the environmental factor, the proximity of an attractive mate, and then there is, this all is mediated by higher cortical processes. Remember this slide, because at the end of my presentation this slide will come back. So this is a delicate and very relative balance. And this hyperactive sexual desire disorder, and we could call it short a lack of sexual desire that causes distress, this is a small this disbalance that occurs to 10% of all women, especially at middle age. And what do these women literally feel? I let down my partner, I feel unhappy, I feel disappointed, I feel upset, I feel frustrated, I feel inadequate, I feel less feminine, and they feel failing on sexual issues. So this is very important for the consulting room, that you know what kind of complaints these people come. Okay, let's start with the estrogens. When you have a shortage of estrogens, like in menopause, you get hot flushes, everybody knows, sleep disorders, vaginal, you get mood swings, vaginal atrophy, and vaginal dryness. And all these things have negative effects on your sexual function. Also, on a physiological level, the basal vaginal blood flow in postmenopausal women goes down. But that does not mean that the function goes down. Sufficient erotic stimulation can compensate for this loss of vascular capacity. And what the senior gynecology thought, if you were atrophic, that did influence the possibility for lubrication. That's not true. Atrophia, if you are very atrophic, and we know from research, you show an erotic movie, the vagina wall functions. So atrophy does not exclude sufficient lubrication. But first is when you give postmenopausal women estrogen substitution, you can do that locally, vaginal, or as well systemic, then you see that this vaginal dryness and dyspareunia disappears, you feel more pleasurable in the area, lower urinary tract symptoms decrease, you have not more any urinary tract infections, so you see complete recovery, but realize there is no evidence for a direct effect of estrogens on sexual desire, arousal, and orgasmic response. The estrogens are purely for your genital health. That's very essential. There are more things which are very good for your genital health. That's frequent sexual arousal and activity. That maintains genital sexual health as well. You can tell it, use it or lose it. So you have to use it. And realize that the aging process affects the sensitivity of the sexual system centrally as well as peripherally. So all the people need more and longer and direct stimulation to experience the same as when they were young. So that takes time. And realize with age, sexual disorders in elderly people, they increase, but they form less of a problem. So this accentuates the importance of psychosocial skills. Now we go to our main subject, the testosterone. Generally, there's a strong tendency towards dichotomous clarity. Testosterone and androgens are male and do not belong to women. And conversely, estrogens are female and do not belong to men. Here you see my estrogens when I was 10 years younger. And here you see the estrogens of a woman who is menopausal. So you see, I have much more estrogens in my circulation than a woman of a similar age. So that means that, and I will show you another slide as well, that in women, androgens during the menopause are very dominant. And even in the period that she is still having her menstruations, you will be surprised how high androgen levels women have in their circulation. What do these androgens? Testosterone facilitates. It facilitates the sensitivity for sexual stimuli, the frequency of sexual thoughts and fantasies, nocturnal sexual responses, the sensitivity of the genitals, vitality and strength of the muscles. So in short, testosterone makes brain and body sensitive to sexual stimuli. Then it is good to realize that women are more sensitive to testosterone than men. And testosterone has similar effects on behavior in men and women. Testosterone has been associated with behavior driven by social interaction, in particular competitive and sexual behavior dominance. And socially challenging stimuli and social behavior can the other way around induce increases and decreases of testosterone levels. And finally, if you have a shortage of testosterone insufficiency syndrome, that you notice there is less sexual arousal, less frequency of sexual thoughts and fantasies, remember Claire, less nocturnal sexual responses, less genital sensitivity, loss of vitality, fatigue, and less muscle strength and volume. In life, humans have testosterone peaks, females have testosterone peaks. And this is the first peak, that is with the adrenal arteries. At 7 years of age, you see that the adrenal gland starts producing testosterone. It produces testosterone through the whole life. There's a gradual decrease, independent from menopausal transition. The next peak is when the ovaries start functioning at puberty. And here you see that during menopausal transitions, the estrogens fall down, but testosterone will continue to be produced by the ovaries. So in the menopause, when you have your period that you go from fertility to the menopause, in the menopause, then the ovaries stop producing estrogens, but they continue producing androgens, sometimes for 12 years. So these are not dead organs, they are still functioning. When I was a gynecologist, and a woman came with 45 years in 1978, and she had to remove the uterus, we said, okay, let's take out the ovaries as well, because you can get cancer from it. Nowadays, even if a woman is 55, we say we just leave it over there, because you have to remove too many ovaries to lower the chance of malignancy, and you take away her androgens. So we don't do that. This is a slide about a peak when you are in love. In women, you see a peak. In men, you see that it decreases. But it's only one investigator who convinced us that it was the case. This should be repeated, this research. It's very difficult. Ovulation, then you see an LH peak, which means increasing testosterone with increasing sexual activity, awareness, sexual motivation, masturbation, genital arousal. During pregnancy, the placenta produces human chorionic gonadotropin, which gives increased LH, which gives increased testosterone. And there are women who, during pregnancy, for the first time experience to have an orgasm or to have multiple orgasms. When you use alcohol, you also see increase in testosterone, at least when you limit it to 2 units of alcohol. If you continue drinking, then SHBG, that's globulin produced in the liver, that falls down, causing an increase in testosterone, and this can be the result, so never do that. But chronic alcohol abuse is also dangerous for men. Alcohol is toxic to the testicles, so testosterone decreases and damages the liver, which means that the estrogens will increase and they get development of breasts. And here you see how in the sometimes during menopause that there is a sharp fall of the estrogen levels. Sometimes it's more gradually. You can read the slide. But if you have a very sharp fall, what happens of estrogen, then that globulin from the liver will go down, gives an increase in testosterone. So these women come to the doctor to say, I do not recognize me anymore. I'm so aroused. I feel ashamed for my husband because I was never like that before. But you can be sure that because it's a temporary phenomenon, so it will disappear. And then the iatrogenic menopause, because of cancer, the ovaries are removed, then you get this kind of thing. And this has a very big consequence because you see that the contribution of the ovaries to the testosterone is very high. So what happens is, here you see it in numbers. Walk with me. This is the mean plasma hormone levels in pre and postmenopausal. Here is the estradiol in the reproductive age. Then in the natural menopause, it's below detection limited. In the surgical menopause, the same. Here you see testosterone and DHEA, which is a precursor of testosterone. Testosterone comes from this. You see that with natural menopause, testosterone decreases with 50%. But if you remove at an earlier age these ovaries, you see that testosterone diminishes with 75% and with 70%. So androgens, I told already, are dominant during the menopause, that's clear, and androgen levels fall more sharply after surgical removal of the ovary than after a natural menopause. That's the message of this slide. This, here you see the adrenal glands, the ovaries producing precursors. Here you see the plasma testosterone, and I told you several times, this is the liver, and here is that sexual binding globulin. It's a kind of thermostat which fixes the plasma testosterone very strongly, so only 1 to 3% of the plasma testosterone is available for the body. The rest is very fixed to this. And I told you, estrogen, when it goes up, as ABG goes up, it grabs testosterone away and the testosterone goes down. Researchers tried to find a correlation between the hyperactive sexual desire disorder and that plasma testosterone level, but they did not succeed. And that has to do with inability to quantify production and action, but it has more to do with the phenomenon of intracrinology. What do we mean by that? The testosterone activity takes place within the cell. So here you see the precursor comes in the cell, testosterone, and the test itself is inactive, it becomes D2-testosterone, that's the active form. So it works in the cell, and then it is coupled to a glucoamine, we call that, and that's going out of the body. So that means that activity takes place, as it were, behind the curtain. There's the testosterone. We do not see what the testosterone is. It's hidden. And it's hidden especially behind the curtain of the cerebellum. There is where the action takes place. And this is very complicated, especially for psychologists, but I made it more schematically. You see all pluses and minuses of all these transmitters and all these hormones, but what in fact is going on in the brains, that there is delicate balance between inhibiting and stimulating factors. So for sexuality, stimulating factors are testosterone, the estrogens, progesterone, and dopamine. Estrogens indirectly. And the inhibiting factors are serotonin, prolactin, and opioids. And you do not have to know them, but realize that it's very complicated. We do not know much about it, but it's a complicated balance. And that means that hyperactive sexual desire disorders can be the result of an increased level of inhibitory activity or a reduced level of excitatory activity. And we call that neuroendocrine imbalance. And this neuroendocrine imbalance can be caused by hormonal disorders that alter the sensitivity of the sexual system, and cognitive disorders that can alter genital and subjective sexual arousal. So, as well as biological factors, as psychological factors can influence the sexual function, namely at the brain level. So, neuroendocrine imbalance can arise from sexual hormone deficiency, psychorelational issues, social cultural factors, medical conditions, and medications. So, it's multifactorial. That makes it so difficult. Medical conditions that may affect psychiatric conditions, incontinence, cancer, recent surgery, we talked already, chronic pain, endocrine disorders, neurological disorders. If you look into detail, neurological disorders, brain injury, stroke, epilepsy, Parkinson's disease, spinal cord, multiple sclerosis, peripheral neuropathy. Medications, I won't go into the fact, but very famous for their work on sexuality are the antihypertensives, the antidepressants, the androgens, oral contraceptives, opioids, the anti-epileptics. Psychological factors, I do not have to tell you, psychologists, relationship, anxiety, fatigue, stress, lack of feeling of safety, poor body image, low sexual image. And then endocrine disorders like hyperprolactinemia, hyperthyroidism, metabolic syndrome, adrenal disorders, and estrogen deficiency. And let's look to the androgen deficiency, because we started with Claire. Claire is an example of androgen, loss of pituitary gland. But you can also lose testosterone when your ovaries stop functioning before the age of 40. We call that premature ovarian failure. It happens quite a lot. The Turner syndrome, adrenal gland failure, suprarenal insufficiency, brain damage. So these are all factors which you can expect that there might be a deficiency of androgens. And there is one disease I want to mention separately. I will explain you why. That's the androgen insensitivity syndrome. These are XY men with non-functioning androgen receptors. So they have androgens, even very much, but they have no receptor. So they look like female, they have normal breasts, they have a blind vagina, they have slightly elevated gonadotropin, and they have very much androgens. And these women, you read it well, they have a heterosexual orientation, they like to have sex, they have normal sexual responses, and are usually capable of intercourse. We do not understand anything about it. Apparently, androgens are not an absolute prerequisite for sexual function. Nevertheless, testosterone has been used off-label since the 1930s to treat reduced sexual desire. And from this period, from 1950, 60, 70, there were many clinical trials who demonstrated that when you give first always give first estrogens, that's research. If you advocate testosterone to it, this improves sexual function scores for postmenopausal women. But the testosterone preparations that were used were in fact preparations not designed for women, much too high concentrations. So you got too high concentration of androgens with all the side effects of it. So that's not acceptable. Then in 2005 we got this small thing. This is the Intrinsa, a transdermal testosterone patch, 300 microgram a day, which is specifically made for women, which gives a safe level of testosterone according to what a little bit more, but it was really a fantastic development. Now, researchers started to see how it worked, and when they gave a combined treatment, it had a positive effect on reduced sexual desire in women whose ovaries had been removed surgically. Also, there was an identical effect in women during natural menopause with hyperactive sexual desire as well. This, no doubt, it works. Here you see they tried to give only testosterone without estrogens, and apparently it worked during natural menopause, but was insufficient during premature surgical menopause. And here you see Kingsburg with several randomized controlled trials, and he saw sexual satisfying events increasing per month in comparison to placebo significantly, as well as for surgical menopausal women as natural menopausal women. So it looks very good, but also this drug had androgenic side effects, even 30%. And what are these side effects? Androgenic alopecia. You get baldness, and you get these, the Germans call it Geheimratsecken. In men you see this baldness. Seborrhea or acne, hirsutism, hyperlipidemia or impaired liver function with a decrease in HDL cholesterol. HDL are the good cholesterols. So you do not want to decrease them, but it happens. And there are also very serious contraindications, for example, high risk of breast cancer and endometrial cancer. But still, these plasters are the best approach for preempting androgenic side effects, and they work. So, in fact, it's a good drug. And you always can discuss with your patient, we can prescribe it, but it has certain disadvantages, and she can decide herself whether she wants to use it or not. And always use it, not for a long time, but for a short period to see whether it's effective or not. But the United States Drug Administration gave no approval for this plaster, principally because of lack of long-term safety guarantee. The North American menopausal drug was okay when you give it to postmenopausal women with decreased sexual desire associated with distress and no other identifiable cause. These women may be candidates for therapy, what I said, at the lowest dose and for the shortest time. The British Drugs and Therapeutic Bulletin recommended against the use of the testosterone patch, but the European Medical Authority approved the Intrinsa testosterone patch for surgical menopausal women with HSDD. So in Europe we were lucky that we could use this for this group of patient support, because then the insurance is also paying for it, because it costs about 40 euro a month, so it's a very expensive drug. But a therapeutic dilemma, one group of specialists says, do not use it, the other one, do use it under these conditions, another one, you can easily use it. But this dilemma has been solved because in 2012, this drug was taken from the market purely for commercial reasons. So it was not, they just stopped the production of drugs. So we lost the Intrinsa path. In Europe, we have another alternative that is tibolone. Tibolone is a synthetic hormone, so not a real hormone, synthetic hormone, and it has an androgen, progestogen, and estrogen effect, and is already used in Europe for climacteric symptoms since 1991. And one of the side effects is that it activates progesterone and androgen receptors. It reduces SHBG, there's more testosterone available, so it functions. There was Mrs. Nederland, Esme Nederland, she was in our institute. She did a multi-center, double-blind, randomized clinical trial in 572 patients. She compared tibolone with a placebo and found significant increase in desire and frequency of arousal in sexual fantasies. So we use it as a possible pharmacotherapeutic agent in postmenopausal women with sexual problems and sexual dysfunction. And nowadays we also use it for women who lost their ovaries too soon. And always, but I think that's with all the drugs you get, always the lowest dose and always the shortest time. So it has a direct effect, and the tolerability and safety profile is sufficiently established. There are alternatives, at least we thought there are. Here you have DAEH. That's the precursor cholesterol you can give, but research showed conflicting evidence, so this is not used for this indication. Another alternative was sildenafil, the Viagra of men. Does it work for women? It works for women, but not for desire. You see, sildenafil provides more benefits for arousal disorders, so you see that the vaginal amplitude is increasing, but less for sexual desire. Then there is flibanserin, which is originally an antidepressive drug. And when you give that in 100 milligram daily, it is effective and well tolerated for the treatment for HSDD in postmenopausal women. But again, the USA FDA advisory panel spoke, and they said the benefits of flibanserin do not outweigh the side effects such as dizziness, nausea, fatigue, and somnolence. So in October 2010, they stopped development of this product. But this year, very recently, the Groningen trial came out where they tested in premenopausal women the effect of flibanserin with placebo on a great number of women. And they found that flibanserin was very effective in increasing the number of satisfying sexual events in sexual desire and the decreasing of sexual distress. And then, surprisingly, on June 7, 2013, this firm confirmed they had resubmitted flibanserin for FDA approval. So probably it will go back in again. Now, this is a very rare alternative, bremelantomide. I think you should forget it. They had it for nasal application, intranasal dosage, but people got high blood pressure from it, so now they are experimenting with subcutaneous form of this drug. And finally, bupropion. Bupropion was also suspected to be very good for sexual desire, but there are some randomized controlled trials, and it increased arousability and response, but not desire. But still, bupropion is the antidepressant which is most friendly against sexual disorders. So if you have a patient who needs antidepressants and sexual complaints, you should always, if possible, choose for bupropion. To summarize, pharmacological treatment options, you will have noticed, are limited. So it's a very turbulent process which is going on. The focus is on the addition of testosterone to hormonal replacement therapy in surgical menopausal, postmenopausal women. But I think there are more diseases where women are exposed to a shortage of testosterone, like loss of pituitary function. Think of premature ovarian failure, I mentioned already, the Turner syndrome, adrenal gland failure, hyperthyroidism, and brain damage. But more research is needed. A view into the future. You see, the pharmacologists are busy to develop testosterone as a gel spray or sublingual. Sublingual means that you get it under your tongue. And there is a very interesting development of this, what I put here, sublingual testosterone together with Viagra or together with fibrinogen. That's an idea of Adriaan Tuyten. He's working in the Netherlands, is doing very beautiful research, and he and his co-workers emphasized that low sexual arousal could be due to a relative insensitive brain system for sexual abuse, the low sensitive women, they call them, or to an enhanced activity of sexual inhibitory mechanisms, women prone to sexual inhibition. And what they did, they gave sublingual testosterone, and that gave, irrespective of circulating plasma testosterone levels, an increase in the sensitivity of the brain to sexual cues. So they can make the brains more sensitive for sexual cues, but that's half of the story. Because they have the theory of the dual control model, and then that the effects of the increase in sexual sensitivity of the brain depends on the motivational state of the individual. Where did we see that before? I showed you this slide again. So you see here the sensitivity of the steroid receptor system of the brain. That is the effect of sublingual testosterone, and this is mediated by higher cortical processes, and that's the motivational state. So what he in fact is doing is filling the gap between the higher cortical processes and the testosterone sensitivity. So it's a very clever, intelligent step he made. And what he did, so sublingual testosterone, he says, might activate sexual excitatory mechanisms in low sensitive women, or evoke or strengthen sexual inhibitory mechanisms in women prone to sexual inhibition. So what is he doing? He gives sublingual testosterone. This increases the sensitivity of the brain after 4 hours, and then 2.5 hours after giving the sublingual testosterone, he gives Viagra, PDE5, because it works on arousal. Benefits for sexual arousal. The other approach is sublingual testosterone after 2.5 hours, flibanserin, to inhibit the overactive sexual inhibition mechanism in the prefrontal area. So that's very, very clever. So that means he did a randomized, double-blind, placebo-controlled crossover study, low-sensitive women. He gave testosterone plus Viagra, and in comparison with the placebo, and what is first I have to tell you this, they used the ambulatory psychophysiological experiment at home. So the women got these artificial tampons with them in the home situation very safely, and could measure themselves in the first week. And the other 3 weeks they had to administrate how they did and how they felt and what happened within their sexual interaction. But it appeared that this did function, there was subjective sexual satisfaction, they experienced sexual desire, and it could be objectified by the vaginal pulse. The women who did not respond, the high inhibitors, were treated with flibanserin in combination with testosterone, and you see that they had an increase also in sexual satisfaction, arousal, desire, and VPA in comparison to placebo, as well as the combination therapy of testosterone and Viagra. So this is a potential, very surprised, a potential and promising treatment for women with hyperactive sexual desire disorder. The press was very enthusiastic about it and excited. There may be a pill for that. There was a lot worldwide. There was a lot of publicity when this came out. What I am most excited about is that this combination means no adverse events due to long-lasting higher androgen status, which makes the way free for the FDA to agree with using this kind of combination. So I think that's the main message. But there's always a but. Ongoing research of effective treatment modalities should be both medical and psychological. You cannot deny the psychological part of the story. That would be that you see with Viagra. In the beginning, all men were taking Viagra, and then slowed down to a certain level. Especially because Viagra does not work if you, at a cerebral level, are not motivated and not having any fantasies. Then it does not work. So this is very important. and realize the circle of Basson, the circle I showed you that slide with these circles, realize that pharmacological facilitation of sexual arousability will only be meaningful if the treatment also pays attention to psychological and relational factors. Because when a woman has predominantly negative or few positive sexual experiences, there will be only few stimuli that might recall those feelings of excitement. So in the absence of androgen deficiency, I think to offer or not to offer androgens, that's not the question at all. To counsel or not to counsel, that's the question. And in my experience, clinical experience, most frequently the answer. Thank you.